presentation is from Professor Laith Abu Raddad from Weill Cornell Medicine, Qatar. Laith trained originally as a physicist, but then also was led astray into epidemiology, where he has a really broad reputation across a number of diseases, particularly more recently HIV, but also multi-strain dynamics. And he has a fantastic group working with him in Qatar, and he's going to tell us about a very different experience of the epidemic in Qatar. Thank you, Laith, very much for your time.
Thank you very much, Deidre, for the opportunity and for having this very interesting, actually, discussion. So, yeah, I will be describing the story of the epidemic in Qatar. But first, little background about the country. This is a very small country. It's a small peninsula in the Arabian Gulf region. It has a population of 2.8 million people. However, of this total population, almost 90% of the population are coming from elsewhere. These are actually expatriates coming to work. The actual Qatari population is only 11% of the population. Very important fact here as well is that 60% of the population are expatriate craft and manual workers. So these are workers coming here just really to work. With this also background, there is very small fraction of the population who are elderly. So only 2% are above 60 years of age, and only 90% are above 50 years of age. Now, the country has been in very rapid development over the last two decades. This development is fueled by utilization of massive gas reserves, which with this economic development, the country is already have the highest per capita income in the world. And this development drive has brought so many workers and actually other, professionals to the country to work on these development projects. So this is an example of a recent project completed actually right next door to me. This is one of the World Cup stadiums that will be hosting the World Cup in 2 years. Also, as part of this investment in development, they invested heavily in education, research, and also technology. So they even established a city dedicated for these things, which is where I am located, and where several institutions are hosted, including the Medical School of Cornell University, where I am working. So this is just the background. Now, with this kind of demography, we have a very peculiar residential dwelling structure. 60% of the population, these are the craft and manual workers, live in shared accommodations. Here is an example of those shared accommodations. It's called Labor City, which houses several tens of thousands of these workers. So they live in more really dormitory style accommodations. So these workers not only work together during the day, but also they live together for the rest of the day. They have their meals together. They share rooms, they share bathrooms, and so on. So such, such settings, as we know well, can be conducive for respiratory infections. We are all too familiar with the boarding school effect for influenza, where influenza can have a reproduction number well above 10 in a boarding school, even though it's actually well below 2 in the more wider population. So indeed, this was a vulnerability in the country. This is probably the only country in the world where 60% of the population live basically in dorms and shared accommodations. And this was indeed the case. So the very first documented case of community transmission was discovered on a person who was attending the emergency department because of a severe infection. This happened in March 6, earlier this year. And immediately following the discovery of this infection, the persons in his residence or in his accommodation were tested. There were actually hundreds of them over there. And almost 300 infections were identified. So this really created a shock in the country, because we moved basically from no infections in the country to almost 300 infections in one day. It was quite a big shock, which confirmed the vulnerability of the country to this epidemic. And immediately after that, within days, there was a national lockdown where practically everything was shut down, which continued actually for three months. Despite this lockdown, the epidemic actually continued to rise, and in fact was growing very much exponentially. So here you can see the number of cases diagnosed every day. It kept growing, and reached a peak of 2,000, almost 2,500 per day. In this really small population, we are less than 3 million people. But interestingly, and it was very evident that the population most affected by the epidemic are those craft and manual workers living in shared accommodation. This was by far the leading risk factor for the infection. So we kept finding more and more clusters in these workplace communities. But interestingly, most infections were actually quite very mild and quite often even asymptomatic. Here is another view also in terms of the positivity rate that we have been seeing. Positivity rate was also growing exponentially, and it reached about 35%, which is really high at the epidemic peak. So 1 in every 3 tests was actually turning a positive result. While all of this happening and giving the vulnerability to the epidemic, so the country invested massively in expanding testing. And one aspect of testing was random testing, which is focused in the workplace communities, because we knew there must be lots of clusters happening over there. So they start doing random testing in these places. And here are the results of this random testing. The epidemic was expanding very rapidly despite the lockdown, as you can see. And at the epidemic peak, 1 in every 4 tests was actually positive, even though this was random testing. You know, people were tested not because of clinical suspicion or contact tracing, just random testing. It was very, very clear the epidemic was expanding very rapidly in these settings. But also, very surprisingly, what we were seeing is mostly actually asymptomatic infections. I mean, not even mild. The majority of infections appear to be actually asymptomatic. And this was confirmed by a nationwide survey that we conducted around that time in early May. And we found 15% of people were positive for the PCR positive for the infections, but most infections were asymptomatic. So 58.5% of those who were positive did not report any symptom within the last 2 weeks. No symptom within the last 2 weeks. And generally, actually, symptoms wasn't really predictive of infection unless people reported 3 symptoms at the same time. So reporting 1 or 2 symptoms wasn't really predictive of infection, because even negative people reported sometimes 1 or 2 symptoms, but having 3 symptoms of this infection was actually very predictive of being positive. So while all of this, this was really what was happening early in the epidemic. So this brought a big question: why the lockdown wasn't able to halt transmission, even though at the time we have seen experiences, for example, from Europe, you know, which actually just seen one example where the lockdowns or severe restrictions were able to reduce R0 to below 1 and reduce substantially the transmission in the population. Now, it's not really difficult to see why the lockdown did not work in our case. Really, the logic behind the lockdown in its really very simple form, by forcing people to stay home, then people, we sever all connections in society, apart from the connections within the household. But the household, it consists only of a small number of people, so the risk of infection over there or exposure is very, very low. So the lockdown is going actually to work. And this is, I think, what happened in many countries where lockdowns did indeed substantially reduce transmission and brought R0 to below 1. And as we learned, in fact, from our experience here, this was successful for the urban population of the country. I mean, for people who are living in households or discrete housing units, it did really work. But as I will show shortly in terms of seroprevalence data. But for these workplace communities, it really did not work. And the reason, of course, because these communities are communities in reality. These are not small households. So if having just one event, one super spreading event over there will expose lots of people to infection. And this is why we were finding one cluster after another in these communities. This also was easily seen in RT, which was being estimated as we were going through the epidemic. So here is RT calculated using the Robert Koch Institute method. So this is really observed RT. This is not really a model-based RT, just RT from the actual pattern of infections. So as you can see, RT most of the time was well below 3, which is probably the natural course, R0 for the natural course of the epidemic, but it was never really below 1. And this is why we had this exponentially growing epidemic. We were not really able to reduce it to below 1. Just let me bring some comments also about mathematical modeling. So the country really has quite forward-thinking leadership, and they invested a lot in science, in education, and so on. And one reflection of this is actually their interest in having as much as possible a response based on science. So we were part of the national response before even the discovery of the first infection in the country. So what we were doing initially is do forecasting for healthcare and isolation needs, also looking for the impact of a different strategy for restrictions on incidence and flattening the curve. Here is actually one of the very first results we generated to about potential healthcare needs in the country. And overall, the model predictions, which was actually a deterministic age stratified model, so nothing really so sophisticated, was actually very, very predictive of what was happening and what actually occurred. So we were able, with really good, very good accuracy, to predict healthcare needs in terms of acute bed and ICU hospitalizations. And I think we were lucky in this regard because the epidemic was very much an SIR epidemic. We did not have as much really changes over there because the lockdown was immediately enforced after the discovery of community transmission. There wasn't really much time before the lockdown for the epidemic to show a pattern. So this is why I think SIR dynamics worked very, very well over there. Another aspect of the modeling we have done is actually for isolation and quarantine needs. With 60% of the population living in shared accommodations, home isolation and home quarantine is not an option. We could not do that. So the country had to invest massive resources in isolation and quarantine facilities, and we provided the modeling for this. Here is also some of the modeling we have done about different strategies really to flatten the curve, which was eventually flattened thanks to the lockdown. So overall, the peak for healthcare demands, whether acute care beds or ICU beds, was reduced by almost 80%. Modeling has been and continues to contribute to monitoring the epidemic. So predicted correctly the epidemic peak, which again, I think it was just simply because our epidemic was so predictable with very, very simple dynamics. We are, of course, now very closely monitoring R0. So this is, RT. So this is RT over the last few weeks. So as you can see, we are approaching an RT of equal 1. We are slightly on average below 1. So we are still fine. But we cannot exclude the possibility we may have a second wave, but probably actually a small wave if it happens for reasons that I will explain shortly. Probably the most impactful or consequential even of all the modeling work is the timing and manner of easing of restrictions. And why is this? Because initially in the epidemic, after the discovery of the very first cluster, Of course, everyone was scared. There was consensus that we need to go immediately into a lockdown. But shortly after, just it did not take more than, let's say, 2 to 4 weeks, it was becoming evident that the lockdown is damaging severely the major development projects in the country, is damaging the economy, is having lots of harmful effects in society, economy, and so on. So there was very serious discussion that we need to start easing of restrictions. At the time, also, Europe was easing restrictions. Our neighbors also were easing restrictions, which created more pressure to ease restrictions. So the model was used to look for the impact of easing of restrictions. And since we were in the exponential phase growth of the epidemic, clearly that was a very bad decision to do so. And we showed several scenarios where clearly if we start easing, we will have very, very harmful consequences in terms of the epidemic. And we demonstrated really to policymakers that it's all really about timing here. If we are patient enough for a few weeks, we will be able to ease restrictions in a much better way, where we minimize the risk of a second wave, because we don't want really to ease restrictions also only to have imposed them quickly after that. And indeed, it was actually successful, and everyone eventually reached consensus that we have to be patient and to wait and let the model tell us when it's really the earliest time we could ease restrictions. So we went with a strategy of easing restrictions when RT reached 0.7. And of course, the obvious reasoning over there, we wanted to buffer against increases in the contact rate. We wanted to stay as much as possible away from RT equal 1 to prevent a second wave. So this was actually done. And the policymakers appreciated the reasoning, because for them, most important was also stability. The last thing they wanted is to ease restrictions only to keep actually imposing them, whether intermittently or just because of a second wave and so on. So this strategy proved to be actually very successful. So now we are more than 5 months since the epidemic peak, and more than 4 months since easing of restrictions. And we do not have a second wave. So the epidemic declined really rapidly and then stabilized at relatively low incidence. And so far, no sign really of a second wave. And during all of this time, restrictions were gradually eased. And right now, most restrictions have been actually eased in the country. So we are able right now to live really with a lot of functionality back in place. So this was what's happening up to the epidemic peak and start of easing of restrictions. Then we shifted our focus to conduct of epidemiologic studies, also really to support the national response. So the first study we conducted was assessment of the risk of reinfection, because really we wanted to know whether there is substantial risk for reinfections. And we are very well positioned in this regard, because we have a centralized basis for everything related to COVID. Everything, hospitalization, testing, diagnosed cases, everything in one place. So we just digged through these databases in the full cohort of people who had a laboratory confirmed infection, and to see whether there is any evidence that some of them were actually reinfected. And then we investigated every suspected case of reinfection, and we had a criteria to determine the level of evidence for this reinfection. And eventually we arrived that we had 35 cases with strong evidence for reinfection, and 9 cases with weak evidence for, 19 cases with good evidence of reinfection. Then we went one step forward and we did viral genome sequencing of the proportion of only a part of these cases, the cases where we were able to have samples, paired samples for the first infection and the reinfection swabs. And through this study, we were able to confirm 4 cases of reinfection, it was very, very clear the virus is actually a different virus. So there is no question that reinfections have actually happened. And we do have very concrete evidence for them. But really the value of this study was more in estimating the risk of reinfection. And this is really what we wanted to get to in the first place. So the reinfection risk was estimated at 0.02. In other words, it's actually less than 2 in 10,000 laboratory confirmed infections. It is very, very low risk, which suggests that even though reinfection is possible, most people appear to have protective immunity against the infection that will last for at least a few months, which is when we conducted this study. Interestingly, also, none of the reinfections that we identified were severe, critical, or fatal. All of them were actually mild or asymptomatic. Then we moved to seroprevalence, a series of seroprevalence studies. Now, one reason why we wanted really to do this study is that from the model we have, which was also a meta-population model, it was telling us that probably now in the craft and manual workers, we may actually have already reached herd immunity over there, just because of the intensity of the epidemic over there. This was actually the model prediction. So we wanted immediately, once we start having ELISA platforms to be able to do antibody testing, we started the antibody testing. In the first study we conducted, we chose 10 of those worker communities, and we tested them for antibodies, and the result was in fact confirming the model prediction that we had very high level of exposure. So 65 to 70% of them showed actually detectable antibodies, as you can see in this figure. So this suggests that indeed we may have reached herd immunity over there. This was confirmed also by PCR testing, because for some of those communities also we did PCR swabbing at the same time. So PCR rates, PCR positivity was really low, and actually a couple of communities even we did not find a single PCR positive case. So it's much lower than, of course, what we were seeing earlier in the epidemic, where it was very, very high. And even those positive cases, interestingly, the vast majority of them, almost 80%, had a high CT value above 30, which is indicative that really the infection is not really a recent infection. Probably people had the infection a few weeks earlier, but they are still having some viral fragments that keep showing as PCR positivity. So this supports also that really it's likely this population is at herd immunity. And this is also confirmed by the fact that even though all what we're seeing is one cluster after another earlier in the epidemic, we haven't seen any major cluster in any worker community over the last few months. So it suggests also really herd immunity. So in summary, it looks like the classical formula for herd immunity, which we are all too familiar with, 1 minus 1 over R0, which actually, of course, it was part of the very nice perspective that actually Dedra and Roy actually wrote earlier, worked actually very well. This was really predictive of the herd immunity level that we actually reached in this population, which also contrasts with what some people were arguing, that we may reach herd immunity at much lower level, in part because of heterogeneity in exposure. Now, our worker communities tend to be very homogeneous. So it's possible that we may have lower herd immunity if the population is more heterogeneous. But honestly, I'm skeptical that we could have herd immunity at less than 50% exposure in the population, at least based on our experience, the experience we have seen here. Now, this study also allowed us, which is something we are very, very intrigued about, is the severity of the infection. Because really, throughout, we saw lots of infections, but we did not see high severity. So it allowed us to have an empirical estimate for severity. And in over 3,000 antibody positive or PCR positive persons in this study, there were only 5 infections which were severe and only 1 infection which was actually critical ever. So this is a severity rate of only 0.2%. Only 2 in every 1,000 infected persons developed a severe or critical infection per WHO definition for severity and critical. So after this study was in really select communities, in part because we knew some of them were affected by very large clusters. So we said, why don't we do just a nationwide study for all craft and manual workers at the different parts of the country, which was actually done and completed recently. And we found the same results. 2/3 of the workers' populations have already been infected. So it looks like indeed we are at herd immunity over there. And this also study allowed us to have a second estimate for the severity of the infection, which was 1 in 200 here. So for every 200 infections, there was only 1 infection which was severe or critical. So this was within the confidence interval of the first estimate, which I've just actually shown you. This study also allowed us something we were very interested in, which is the detection rate. And it turned out only 1 out of every 10 infections. So out of every 10 people who were antibody positive, only 1 of them had a laboratory confirmed infection earlier by PCR, which is actually agrees also with even what we just have seen from Luke, which the estimate of 1 in 10 diagnosed infections. So this was in the worker population of the country who lives in shared accommodations. Next, we moved to the urban population, and we have been assessing seroprevalence in using actually residual here clinical blood specimens. It's a different study design, and we are doing it actually prospectively. So we are doing a few thousand tests every week now, because we are trying also to track it over time. And just the key results here is that the exposure here was much lower than in the worker population. This is where the part of the population where the lockdown, I think, was really successful. So we had an antibody positivity of 17%, which is way below herd immunity. We had, but interestingly also here is that we saw much lower levels in the elderly population. So even though we had very high exposure in part of the population, the workers, especially in the elderly population, which are most vulnerable to severe disease, the exposure was actually much lower. One of the goals of this study is also to try to monitor how antibody positivity evolves over time. So now we have actually data that allows us to see what happens up to 4 months of infection. And this is very, very large sample size. So as you can see, even after 4 months of infection, people still were antibody positive at a rate of 91%. Which was actually flat very much really throughout. So it's the antibody positivity so far is durable. It's not really going down. In fact, when we look at the optical density, we see also it's strong antibody positivity mostly. It's not really going down. So there is no question that antibody titers have went down substantially, but not to a level where it really changed the classification of strong antibody positivity. So this is really reassuring. It looks like people are maintaining their immunity so far, at least for up to 4 months. Now coming to another study, which is assessment of the severity of the reinfection. This is really, again, it's really one of great interest for me because of how really the epidemic has been quite mild here. And luckily, we have now so much data to inform our model to be able to make an assessment here with so much really antibody, PCR, everything, data, severity, and so on. And here are actually just fresh results, just completed, in fact, in the last couple of days. So the striking pattern we see is very, very strong age dependence. If we take severity of the infection, and I mean by severity is severity per WHO definition for a severe infection, we see the likelihood of developing a severe infection increases very, very rapidly with age. And it's way higher for older persons than for younger persons. Criticality of infection, also per WHO definition, shows even more, even stronger dependence on age, where it's actually very limited for younger people, but it grows very, very rapidly with age, which also seen similarly for fatality of infection, which is practically zero for younger populations, but it grows very rapidly with age for older population. So this, it seems, really explain in large part why we have had overall a mild epidemic, because we had, to begin with, we had very small fraction of the population who are above 50 years of age. Less than 10% are above actually 50 years of age. So this helped us. Also, we were able to reduce exposure in the elderly population. We did not have high exposure in this part of the population. So most infections were really in the younger part, which were able to tolerate the infection quite well. So overall, in terms of severity, there were only 31 severe infections out of every 10,000 infections. And there were 7 critical infections out of every 10,000 infections. And for fatality, there were 2 fatal infections out of every 10,000 infections. So as you can see with these rates, we are actually not well above what we see for seasonal influenza. So age is clearly a very important factor for I think explaining the low severity we have seen in our epidemic. But could there be other reasons? Well, we know from now there is growing evidence that suggests a cross-reactivity to the other cold coronaviruses may actually have something to play here, and which really seems to make a lot of sense for our setting, because the same shared housing accommodations and the fact that our population is expatriate with high travel mobility, it means really we must have had also in the recent past high level of exposures to the other coronaviruses. So could this have been actually been protective? Maybe it wasn't protective against infection, but probably it was protective against severe disease of disease forms of this infection. So we are trying to look, in fact, as we speak into this. Here is actually very, very preliminary results. Again, very, very preliminary, but it seems we see a signature of this. Among asymptomatic and mild cases, we saw higher cross-reactivity to one of the other cold coronaviruses, and lower cross-reactivity for those severe or critical cases. But this question remains, of course, open and it's not yet settled. Another reason which may actually have helped in reducing severity and criticality, but really, in truth, we only have anecdotal evidence. But this is something in the healthcare system here, they strongly believe in, that because we had very proactive and early interventions, and healthcare is universal here, everyone received really excellent care which was also standardized. This may also help in reducing the cases that would have progressed to severe and critical disease or even death. So as you can see from what I have been showing, it's really, it has been a story of an unlucky epidemic, but at the same time of a lucky epidemic in our setting. We were unlucky because our population, we have high vulnerability because of these shared accommodations. But at the same time, still the lockdown was useful in flattening the curve, and which made the health system able to cope up with the demand. At no time we were even close to actually our capacity. Also, we were lucky because we have a small elderly population, And this elderly population had much lower exposure rates to the infection than the rest of the population. Most of infections were actually happening among the young people who were able to tolerate the infection. So now the estimates for the antibody positivity in the whole population is actually almost 50%. So maybe we are not too far from herd immunity overall, but we are reaching herd immunity by only young people getting exposed as opposed to the elderly population. So this brings me to my conclusion. Infectious disease epidemiology is often more fascinating than our imagination can keep up with. In fact, we have just seen, two presentations with two different experiences. And of course, there are many other experiences, including the UK experience. So as you can see, we have a very different type of epidemic, which may suggest that really epidemic expansion globally, we may see very different patterns as well across nations, especially with nations with young populations. So probably the epidemic may not be as bad in this population as we may think right now. So in last but not least, just want to thank the team who has been working on this study, our funders, also the Ministry of Public Health and Hamad Medical Corporation. Hamad Medical Corporation is the equivalent of NHS in the UK. This is the national healthcare provider for their excellent cooperation. And last but not least, just want to thank you very much for listening and for the opportunity to present today. Thank you very much.
Thank you very much, Laith. Fascinating presentation, very broad ranging, and such a different epidemic than many that we've seen presented in this program so far. Thank you, with fascinating data. I'm going to let Luke ask the first question, and then we have one from the floor, and then I possibly have some more if we have a bit of time. Luke, do you want to go ahead?
Yes, thank you so much for this wonderful presentation. It's very interesting. I was particularly interested to hear about reinfections. I was wondering, is it known how antibodies or T-cell reactivity evolved in these few cases with reinfection, and has any cause been established for this reinfection occurring?
Mm-hmm. Yeah, unfortunately, we are only looking at it from the epidemiology side because this was really a retrospective study. So we don't also have samples to do further work, and definitely I do not have that expertise, in terms of basic science. So unfortunately, no, we don't really have more detailed studies to look about, immunity. But at least I can tell you something. In just over half of those reinfections, they were actually antibody negative. Just over actually half of them. So some of them were actually positive, antibody positive, but actually just over half of them were actually antibody negative. So possibly the reinfection happened because the first infection was cleared before even development of antibodies.
Wow. Fascinating. Luke, sorry, did you want to ask another question?
Well, if not, I have another question if nobody else wants to have a go.
Yeah, I have one for the floor, but you go ahead, Luke.
I have a question about the elderly who seem to be underexposed in the Qatar epidemic, which is fortunate in a way because they are at higher risk of mortality. I was wondering, how are the elderly positioned or dispersed in Qatar communities? Is there, like in the Netherlands, they are relatively concentrated by the existence of elderly care homes. In Qatar culture, is it more common for the elderly to live with their families, or are there also care homes? And how do you think this affects the ability to protect the elderly through herd immunity?
Yeah, this is a really excellent question. So for us, I think a lot of really the protection came from families. Within the cultural fabric here, it's really unacceptable for any elderly person to be in a nursing home or in a daycare center. It's always families who actually take care of the elderly. And we are talking also about a country which is very affluent. So all the elderly population basically are Qataris or long-term residents. They are affluent, typically they live in excellent, settings. where it's easy to protect them. It's not like they are living in lots of people in the same household also. No, they are really very, very protected. And elderly tend to be highly respected in the society. So really very much their children took excellent, I think, care of them, and which helped actually protect them against exposure.
Thank you. That's so interesting. It's very different from the Dutch setting, unfortunately, for us.
Yeah. It's very interesting, you know, it's always each infection tests how we are actually responding or how we are living in our life. Yeah, absolutely.
Thank you, Luke. Dennis had a good question, actually, really for both of you, which is, are there other countries which are similar but responded differently, or places that had the same response? You know, so are these two examples completely unique, both in terms of the setting and the response, or are there other examples which were similar in some way?
Yeah, well, I am sure there are many examples that are actually very different in terms of response, you know, and also consequences. Now, of course, it happened for me, really, I know well only the example of one country. This is where I'm actually heavily working, but I'm sure there are actually. In terms of response, definitely. Like I can give you an example, two examples in our region, which are quite interesting. Lebanon and Jordan. Both countries, because they have really a healthcare system which is already heavily burdened, they were very, very worried about the epidemic. So they went with the strategy of extreme lockdowns, really, really extreme. I mean, to the extent in Jordan, the military went into the streets, forcing everyone to stay at home. This actually was very, very successful. For months, they had very, very low incidence. Most, in fact, infection were diagnosed from people who were actually coming from abroad. It was pretty clear there is really no sustainable transmission within the country. So they kept doing this for months and months, but then of course it damaged immensely the economy. It really created lots of hardships. So just in the last few weeks, basically they relaxed things. And the moment they relax things, they are having right now an exponentially growing epidemic. And their challenge right now, because of the restriction fatigue, they are not able to convince the populations right now to actually adhere to restriction measures. And they don't want to go with very extreme measures because they don't want to hurt the economy. So they are actually in a very big dilemma while the epidemic is growing exponentially. So this is the case for Jordan, and actually very similar experience to Lebanon.
So I think, yeah, I mean, one of the successes is the clinical treatment. I think the change in clinical treatment over time has been amazing in Europe and elsewhere. So apologies for my background noise again. Yeah, I mean, I think this, do you think the clinical course, what are the main clinical questions you still have to ask around reinfection? I mean, so what you presented, Laith, as my understanding is, you know, really large, fascinating studies, but, you know, it's sort of the 5 to 6 month timeline that we're starting to see some of these antibodies dropping. Do you think that's just because they've been smaller studies, or you know, what do you think is the signal of antibody decay?
I think to begin with, maybe we are too much fixated on antibodies as proxy for immunity. This is only one component really of the immune system. And even if antibody titers go down, I would not be surprised that the person is still actually immune against reinfection. Just because once this person will be re-exposed, all of a sudden, a massive amount of antibodies probably will be produced to protect against reinfection. So for me, I am coming from the epidemiology side. I mean, of course, I'm not basic scientist also, so I cannot really appreciate, I think, well enough what we have seen from basic science studies. But from my view, our epidemic was very, very classic SIR epidemic. if really people were losing their immunity, we should have seen now massive increase in infections in the country. I mean, the exposures that were, the risks that we had, which caused so many, very, very rapidly expanding epidemic, are still there. In fact, now even we don't have hardly much restrictions. Most restrictions have been eased. Despite all of this, we do not see reinfections, and we do not see, in fact, an escalating epidemic. So it suggests immunity is really, really, really strong. Now, by the way, we are this reinfection study, of course, we will keep updating it because, of course, at some point maybe we'll start seeing signal for reinfections, but at least not yet. But we are right now doing a different study design for reinfection. So in that reinfection study, we looked for reinfections among people who had a PCR laboratory confirmed infection. Now, because of so much antibody testing which has been done in the country, we have also a cohort of people who are antibody positive. So we are looking for the risk of reinfection among them. So these people may never had a laboratory confirmed infection by PCR, but they are actually antibody positive. And from initial results right now, it seems also we have very low risk of infection. It's actually higher than what we have seen earlier, but still very, very low. But the study is just in the making.
Thank you. Yeah, it's really interesting what's going to happen over the next few months. I mean, you mentioned that you're directly estimating the reproduction number, and that was fascinating. We've done a lot of talk about the reproduction number here at the programme and the Isaac Newton Institute. Can you tell us a little bit more about how you're able to do that rather than inferring it?
Yeah, so we have been estimating it through different ways. One is model-based, which is actually the model we developed for the country, which we have been using, and through it estimating R0 and RT as a function of time, which worked quite well, especially in the exponential growing phase of the epidemic. It gave us really an average estimate for RT and actually R0. But in more recent times, this became really not as useful because we are very much at a stable incidence right now. So clearly R0 is, RT is around 1. We continue to actually model it. Now R0, it looks like right now is around 2.5, I think, in the most recent model estimate. But the more useful one really we found is just direct estimation from the data using this Robert Koch Institute method. We also tried actually other methods, but they gave similar results because it's really telling us the observed RT as in where the infection is actually being transmitted. So this really worked very, very well because it really also, we are able through it to see even the impact of small clusters over there. I mean, we had, for example, several clusters during Eid, which was, there were family gatherings and so on. So immediately you can see the impact of on RT. We have this big actually jump in RT, which lasted for almost two weeks. Yeah, so I think both approaches were useful and were used for different purposes in our case.
Thank you. Well, I'm afraid we have to wrap it up there for the live broadcast. So thank you everybody for listening. Thank you very much to Laith and to Luke for two really interesting and really fascinatingly contrasting presentations and two very different epidemics. And I know we'll get a lot of feedback from the attendees on it. So thank you very much, both of you.
Thank you very much. Thank you.